personally, he's a he's a person that when you collaborate with him, very knowledgeable, very great to work with. So, pleasure to introduce Jeff.
Okay. Thanks, Shane. Okay. Great.
Does
So
everybody
today,
know what ISIS is?
yeah, it's the good ISIS.
Okay.
The Institute for Clinical Evaluative Sciences. I will be talking a little bit about our organization.
Okay.
Basically, house a whole bunch of data sets, and we link them together. We do epidemiologic studies with them.
He's with this ISIS, not you.
That's right.
Sorry,
Yeah.
I should have clarified.
Yeah. Okay, perfect. Well, I mean, I'm glad the weather's cooler, so now we can think about influenza vaccines and stuff. So with the cool weather, it's the perfect timing. Okay. So first of all, no financial conflicts of interest to disclose. Here are the learning objectives today. So hopefully after the session, you'll all be able to talk about the latest influenza immunization guidelines, discuss some of the controversies or uncertainties related to influenza immunization. And then also I'll be talking a little bit about this cohort that I've been creating called the Forever cohort, the flu and other respiratory viruses research cohort. Okay, and how we can use it for research studies. Okay. So just a little bit about influenza in case you didn't know. So here we've got a picture of the virus, and you know they have these proteins on the surface. There's the hemagglutinin, HA, and then the NA is the neuraminidase. And these ones help the virus to replicate. And because they're surface proteins, this is how we recognize them and we classify them. So there's influenza A and B are the main types of influenzas. And then there's a subtype. So there's the H3N2. So there's like the third, like the hemagglutinin is the 3 type, and then the neuraminidase is 2. So that's how we classify them as subtypes, H3N2 and the H1N1. And then for the B viruses, they're divided into lineages, so the Victoria lineage and the Yamagata lineage. So in a normal flu shot that we get, there's 3 strains that are included. There's an H3N2 strain, an H1N1 strain, and then either a Victoria or a Yamagata B strain. And now we're using quadrivalent vaccines, so we throw in 2 B strains as well as an H3N2 and an H1N1. Okay. So the influenza A viruses tend to mutate constantly, so there's a lot of drift, and that's why we have to get flu shots every year, because there's new strains emerging pretty frequently. Okay. So every year we have a lot of burden from influenza in Canada. There's estimated to be about 3,500 deaths, 12,000 hospitalizations, another order of magnitude more of emergency department visits, and then physician office visits and so on, and then work absences, and then about 10% of the population will have symptomatic infections each year. Okay, so how can we protect ourselves and others against influenza? So, hand washing, coughing in your sleeve, so called respiratory etiquette. Social distancing, so if you're sick, then you stay home instead of coming into work and infecting everyone else in your office. Like, especially an open office like this, one person's sick, and then next thing you know, everyone else gets sick. We can use masks or respirators, more for healthcare workers who are, getting very close to patients. And then annual immunization. And so we can get the injected flu shot or the inhaled, the intranasal for kids, also known as flu mist. And now it used to be there's like one choice, one option, just the flu shot. It was only one type, so that was the vanilla flavor ice cream. But now there's lots of other choices. So we have inactivated and live attenuated, trivalent, which is like 3 strains versus 4 strains. Some of them contain adjuvants, so that we put in like this compound that helps to boost the immune response to it. We use it mainly in the elderly, but there are adjuvanted that also, I think, they're for children as well. And then there's high dose versus standard dose. That's like a new thing, the high dose vaccine. And then how it's given, whether it's intramuscular, intranasal, and then there were some intradermal, but I think they're not on the market right now. So here are the guidelines, the latest guidelines. This year they haven't really changed compared to the previous year, so this is pretty standard. So we should be giving it, like really anyone is recommended to get influenza vaccine as long as they're over 6 months of age. But this is the list of people who are particularly recommended because they're at high risk of getting complications or being hospitalized from influenza. So it's older adults, so 65 or older, young children, so 6 months to 6 years, 5 years, sorry. Pregnant women, because they're at high risk of being hospitalized during pregnancy, and also to protect their newborn infants, because we don't give influenza vaccines till after 6 months of age. So during that period, from 0 to 6 months, the babies are vulnerable, and so they're protected if the mother gets the flu shot during pregnancy. And then individuals with chronic health conditions. So there's a whole list of chronic conditions that because of their chronic conditions, getting influenza can tip them over and lead them to be hospitalized. And then also residents of nursing homes and other chronic care facilities, and then indigenous peoples who are also at higher risk epidemiologically of being hospitalized for influenza. Okay, and who else should be getting influenza vaccines? Well, people who are capable of transmitting influenza to those who are at high risk. So this includes all healthcare workers, both in facilities and community settings, and household contacts of high-risk individuals, those who provide childcare, whether it's at home or at a daycare, and people who work, essential community service providers, so firefighters, and policemen, etc. And then lastly, poultry workers, because they may be in contact with avian influenza, and then they can get avian influenza and human influenza, and then it can be mixing, and that can be bad. Okay, so how many people get flu shots every year in Canada? This is just data from 2013-14. You can see that there's quite a bit of variability between provinces, with a low of 24% in Quebec, a high of 45% in Nova Scotia, but overall about 3 in 10 Canadians, or about 11 million Canadians, will get the flu shot every year. So this is a thing that lots of people are getting year after year. So it's good that we study how well they're actually working, and that sort of thing.
Okay. Over the years, has it gotten better or worse?
Over time, we're kind of plateaued. It's around roughly 30-something% every year since, I don't know, the last 10 or 15 years or so.
What are the you talked about all the at-risk groups, and this is the general population. What about if you segmented the at-risk population?
Yeah.
What proportion of them get?
Definitely it's higher. So amongst older adults, it's higher. But actually, that's an interesting thing. Is it's actually going. It's been declining amongst older adults. I don't know if they're just getting tired, fed up of getting flu shot every year, or if they perceive that they're healthier. So like the new people who are becoming 65, they feel like 65 is like it's the new 75 or whatever, right? The new 55, yeah, sorry. Yeah, 65 is young now, right? So, so people who are, working well into their late 60s, and so they don't think they're young, they're old, and they don't feel that they need to get a flu shot. So, but in general, though, the high-risk groups do have higher vaccine uptake rates. Okay. Except for pregnant women and young children. We're doing really badly in those groups.
And Aboriginals.
I don't know about that, actually, yeah. Okay, so how well do they work, and how do we evaluate their effectiveness? So they do work. This is a meta-analysis that was done about 5 years ago, where they showed that the inactivated influenza vaccine in adults, IV in adults, is about 60% effective. Okay, when they pooled, these are data from randomized controlled trials, so this is gold standard evidence. And using PCR confirmed, lab confirmed influenza as the outcome. So that's the best estimate that we know of. When we work out the math, it works at a number needed to vaccinate of 64. So that means if you vaccinated 64 people, we would prevent one person from getting lab confirmed influenza. Because it's not like everyone's getting influenza infection, and so you have to take that into account. Okay, in children, because they have higher attack rates, so a lot of children get influenza because they're so good at sharing their viruses. And also the live attenuated vaccine was found to be more effective in the clinical trials. So they came up with a vaccine effectiveness of 83% and a number needed to vaccinate of only 8. So if you vaccinate 8 kids, then you'll prevent one of them from getting lab-confirmed influenza. So this is data from before the 2009 pandemic. So just keep in mind these numbers are 83 and 60. Okay. And in older, so then we use, but it's not practical to do randomized controlled trials because they're very expensive and it's hard to do them every single year. So there's something else, another method that we're using to evaluate a vaccine effectiveness, something called a test negative design. And so this is a type of observational study where you take people, you test a whole bunch of people who come in, like if they come in sick, you swab them and see if they have influenza or not. And the ones who do have influenza, you count them as cases, and the ones who test negative for influenza, you consider them as controls. And so it's kind of like a nested case control study. Okay, and so the benefit of this is you remove the confounding that comes from the health-seeking behavior. Okay, so I'll just show you a schematic here. So these are people who are patients, let's say, outpatient clinics, and then some of them will have influenza-like illness, and then they get swabbed. And so the ones who test positive are set aside in one group, and the ones who test negative are the rest of them. And the red ones are the vaccinated, and the black ones are unvaccinated. So you look at how many people are vaccinated amongst the test positive, and you look at how many people are vaccinated amongst the test negative, and then you can calculate an odds ratio, and then from there you just do 1 minus odds ratio, and you generate the estimate of vaccine effectiveness. And so you have a case definition. They have to have fever, cough, etc. In order to get swabbed. They have to have been swabbed within 7 days of their symptom onset of illness, and then they test them normally by PCR, which is the best test for identifying influenza. And so this is a comparison of the test negative design against randomized controlled trials, and so you can see that when they took the data from RCTs and they reanalyzed them using this test negative design using different control groups, and they found that the estimates were very similar to the RCTs. So influenza vaccines also work for older adults. So this is a meta-analysis using data from a whole bunch of test negative studies, and they found that vaccine effectiveness of about 50%. Even with the vaccine mismatch, they still found a vaccine effectiveness of 36%. Yeah.
I'm just a little confusing. Every year it's a new vaccine.
Yeah.
With new strains and new stuff. So you could think that there is different efficacy with the different vaccines.
Exactly.
So one year it's effective,
Yeah.
more effective than in other years.
Yeah.
So
And
isn't it also dependent on what's happened that year?
Totally. And that's why that's why we're doing these studies every year in a whole bunch of different places. So in some places, so you have to look at the epidemiology of the virus, of the circulating virus in different countries, right? So different countries, you've got different viruses circulating, and then you have the vaccine products, there's different vaccine products being used, and then you have to look at the effectiveness of this vaccine in this country in this year circulating. And then there's also different strains circulating at the same time in different places.
So how does it work then with these meta-analyses that are pooling it across probably years and pooling it across countries and places? Because that's kind of a pooled estimate of vaccine effectiveness across.
Totally.
Okay.
Yeah. And the issue is that, so when you look at season by season, country by country, you're going to see differences. And by pooling it, you're going to lose those differences. But at the same time, if you want to say, how well did they work in general, right? It's not like saying, how well did it work in 2014-15 in Ontario? You're just saying, how well did it work in general? Because, looking forward, nobody has a crystal ball. Nobody knows, whether we're going to have an H3N2 season or H1N1 season, and that sort of thing. So you just want to know in general. Okay. And then they've done more and more of these where they look at it by subtype. So you can see here that the H1N1 subtype is 60% effective, but then H3N2 is about 33% effective, and then B is 50% effective. So in general, you'll see that the vaccines are not working as well against H3N2 compared to H1N1 or B. And so it's kind of bad. Like in general, we see that H3N2 generally causes more severe disease, and then we have the vaccine that we have against it doesn't work so well, and so those, that's a formula for like badness. So like last year we had H3N2 season, it was kind of a bad year. This year, who knows what's going to happen? Maybe I think in the southern hemisphere they were having H3N2, so we'll see if we get that this fall. So we'll see. And especially in the older adults, it was not statistically significant. Okay. So now I'm going to talk a little bit about the impact of repeated vaccination, because this is something that's been a bit of controversial in the literature the last few years. So this was a hypothesis put forward by a guy called Derek Smith as far back as 1999. And so he came up with this hypothesis called the antigenic distance hypothesis. And so even back as early as the 1970s and 1980s, there are some studies suggesting that getting the flu shot repeatedly, people who got it repeatedly did worse than people who just got it like the current year. And so he kind of came up with this explanation for it. So basically, vaccine 1 is a vaccine that you got last year. Okay, so you get the vaccine, and then you have all these B cells, and then they develop antibodies against this vaccine, and then this is called a ball of stimulation. So your body is used to this vaccine. It's been trained to recognize this vaccine. Okay, so you're going to develop. If it sees it again, it'll develop the antibodies and attack that virus. What happens is if you get vaccine 2, which is this year, if it's similar to last year, antigenically similar, what happens is the antibodies that you had against last year's vaccine will neutralize this year's vaccine, and you won't develop as good of an immune response for this year's vaccine, compared to if you weren't exposed to last year's vaccine. Okay, so that's because there's this overlap between these two balls of stimulation here. And then what happens is that if the epidemic strain this year is here, you're okay because you have some protection from last year's vaccine, even though you didn't develop a response to this year's vaccine. But if the epidemic strain is over here, then you're in trouble because you didn't develop the antibodies to this vaccine, and you only have the antibodies to this vaccine, and then you have no protection. So this is sort of the mechanics of how you might do worse if you had vaccines 2 years in a row compared